So one of the things that comes with talking about the tired patient, it's been a sort of, I think you can call it a controversial topic for probably the last 10 years particularly. And you think, well, if you've got a tired patient, you want to know what's wrong with the tired patient, why not just do every test you can think of and you'll find something. But the downside of that is there are issues with over-investigation. These can be not only resource issues, so you're actually spending money investigating Mr. X when you could be vaccinating baby Y, or spending the money other ways, or talking to people about their diets or other types of things. So there's issues there with over-investigation, but also with over-investigation, you may actually spend more of your time following up false positives than actually helping the patient. So if you have a think of the way we set reference ranges in pathology, often you'll think, well, why do they say 135 to 145 is a reference range for sodium? Well, that's because if you have a look at the general population, 95% of your people will fall between those two figures, 135 to 145. But it also means that there is going to be 5% of your population that lie outside, so usually it's 2.5% on the top, 2.5% at the bottom, of completely normal, healthy people could well have a sodium outside your reference range. If you've got no real reason to think about what their sodium is and you measure sodium, then 1 in 20 patients you're going to be chasing up their sodium results for no good reason at all. So it really comes back to the question of what's sometimes called pre-test probability and how the test then affects it. So if you've got a very rare condition and started testing everybody for it, you'd find you'd have a lot more false positives than true positives, and you'd be spending a lot of time doing stuff that wasn't really helpful. So it also applies to the case of someone who's presenting tired, because there's probably, if you look at the figures, something like between 7 and 15% of GP population, their main problem is they're feeling tired or fatigued. So it's a big group, and I think in this situation it's another place where guidelines play an important role, so you can get a sort of a balanced look at what approaches you might take. And again, what is the context of the testing? And these sort of questions that I'll come to in a minute, it depends. Is this tiredness out of the blue, or is it something that the patient's not really well otherwise? What signs and symptoms go with it? Do I need to test now? Can I put off testing later on? Is there anything more than just minimum checking that I should do? And this is what the guidelines really address. So the main guidelines I'm going to look at, this is from the Australian Family Physician, which is a very good article, Fatigue, a Rational Approach to Investigation, from 2014, but really things haven't changed since then. Now this is the whole guideline, but we won't go into all of it. I'll just highlight a few bits of it. The two things I want to highlight is that an important part of it is the history and examination. So if you think in medicine, I think it's a good rule of thumb that 90% of your answers really come from your history with a little bit of examination. Pathology is often, although pathology is involved in a lot of diagnosis, usually it's not what makes the diagnosis, it supports the diagnosis, but usually a lot of what you need to know is really in the history and some simple physical examination. In blue in the protocol are the two parts that actually do involve pathology testing. The first part is sort of clinic-based pathology tests you might do, so a urinalysis, so the dipstick of the urine, largely looking for proteinuria and glycosuria, maybe also looking to see if they've got likely to have a urinary tract infection, but largely looking for renal impairment and diabetes. And because dipstick of glucoses aren't the best way to do look for diabetes in a realistic way, then if possible a finger prick glucose test would be a reasonable thing to do in the clinic. So that's that bit at the top. Then you go through some other questions and you come to the second part of pathology testing, which is a very simple set of tests, if you want to have a look at it that way. But if you do think there's other specific, if you have very good reason to do other things, then certainly do other testing. But in a patient where you're not really convinced that there's a problem that you're going to find, then at least doing these set of tests. And so full blood count is looking largely for anemias or for lymphoproliferative disorders. EUC is electrolytes, urea and creatinine, so that's screening for a few different disorders, so renal disease with a creatinine and electrolytes. If you've got a low sodium, then you might be thinking of hypoadrenal situations, such as Addison's disease. Liver function test, generally having a look for what state the liver is. Probably find that a lot of chemical pathologists don't like the term liver function test, even though it's standard, because remember, things like AST also come from red cells and muscles and other places. So although AST is part of the liver function test, it doesn't only come from liver, just like alkaline phosphatase is part of liver function test, can come from liver, but can also come from bone. So don't get set on it being all about the liver when you're looking at liver function tests. C-reactive protein on the ESR is a marker of inflammatory conditions. BGL for blood glucose level, a TSH for hypothyroidism. Hypothyroidism is sort of usually of slow onset, and sometimes you might not notice, particularly even in a general practice where you're seeing the patient relatively frequently, they might slip into hypothyroidism without you really noticing it, and then when the locum comes along, I think, gee, this person's hypothyroid. So it's something that can develop slowly and makes it particularly hard to pick up. And then ferritin is another looking for iron deficiency as a cause for fatigue. But in terms of who should get pathology tests, the other important part of this protocol is this bit, the central bit that feeds into whether you should be doing these other tests is largely what they call red flags. So these are situations, things that will flag this patient as likely to have a real, when I say real, certainly things like depression and other life problems, and there's lots of things that are real, but in terms of things that are going to show up on our pathology tests, these are red flags which will move you down into the pathology testing point of the diagram. So to go through them, so if you've got a recent onset of fatigue in a previously well older patient, that's considered a red flag, so they've been going along well and then they're suddenly becoming more fatigued. Unintentional weight loss, so either by measurement or otherwise people saying their clothes are fitting more loosely, that's a very good indicator of weight loss, and it's unintentional weight loss, so if a lady's very happy she's lost weight because she's working very hard, or a guy's very happy that he's lost weight because he's been working very hard, and that's fine, but it's unintentional weight loss. Any history of abnormal bleeding, so that can be an indicator. Shortness of breath is another sign that something actually is happening beyond just fatigue. So some of these questions are really trying to tease out, is this person really just presenting with, if you like, pure fatigue, or are there other things going on that we need to use as markers that something else is happening? So if there's shortness of breath, they may be due to anemia, heart failure, arrhythmias, atrial fibrillation is common in the older population, or developing chronic obstructive pulmonary disease. Unexplained lymphadenopathy, so if they're fatigued and they've got some unusual bumps, obviously that would be a flag that you need to think much more carefully about. Lymphadenopathy as a more common example, but obviously any other unusual lumps. Whether they've got a fever as part of it, so some people might not actually realise they have a fever, so it's important taking temperatures. And then this is just really a catch-all phrase of any recent progression of symptoms, and the type of things they're talking about is things like arthritis, onset of Parkinson's disease. Celiac disease has been flagged as something that's sort of one of those things that can sneak up on people and cause fatigue. So looking at considering whether they have any evidence, either a family history of celiac disease or some sort of food intolerances or a funny diet that sometimes comes about because they avoid particular foods, could be a flag for looking for celiac disease. Then other things like multiple sclerosis, which usually has other features like diplopia or paresthesias or weaknesses. And hemochromatosis is, again, I was talking about hemochromatosis probably coming through from the Nordic states, because that's just where they find, if you go back far enough in ancestry, it seems to have originated from Norway and then spread across the rest of the world. But hemochromatosis, we probably have 1 in 200 people have hemochromatosis, which is a disease of iron accumulation, which means that probably 1 in 8 or 1 in 10 of us are actually carriers of the sort of white Anglo-Saxon sort of population, or even Mediterranean population. 1 in 10 are going to be carriers for hemochromatosis, so it's a relatively common condition, and again can sneak up on people slowly because they may have been accumulating iron from their 20s, or with ladies maybe from when they stopped menstruating, but it might not show up for another 10 or 20 years from when they started accumulating iron. So just to pull out that bit about what gets us to the laboratory lab tests, if there's some somatic disease, so there's some actual physical features you can find, or if those red flags are present, then you go straight to that laboratory testing. Otherwise, you do a trial of lifestyle advice, and then the other thing that a lot of particularly Australian ones, but even some of the overseas ones recommend is sort of watchful waiting. So you ask them to come back in a month's time, having tried some of the lifestyle interventions. People said, oh, won't this make people anxious, or won't people be upset they're told to go away for 4 weeks? When they've actually done studies of it, and people are usually quite happy to wait 4 weeks if you explain to them what the idea is. And if after 4 weeks their fatigue persists, then you also go on to that set of tests. I just thought I'd talk about a couple of those specific tests we've mentioned. First, I mentioned hypothyroidism, just to refresh your mind. This is the thyroid gland, is the pink angel wings sitting there. And so the thyroid gland is driven by the thyroid stimulating hormone that comes from the pituitary. The thyroid gland produces the T3 and T4, and when we measure in the laboratory we talk about free T3 and free T4 because they're bound a lot to proteins, and it's the free fraction that makes a difference. And so that's the axis. So if you've got someone who's hypothyroid because their thyroid isn't working properly, then their TSH will go very high because the pituitary is trying to get the thyroid to do what it's supposed to be doing, and if the thyroid can't do it, then the free T4 and the free T3 will be low. And that's hypothyroidism due to thyroid disease itself. Or otherwise, if you've got the hypothyroidism due to pituitary disease, then you'll have both a low TSH and a low free T4 and free T3. The importance of thinking about what that might be is that if you look at the medical benefits schedule for thyroid function testing, you're really only allowed to order a TSH as a first-line test because most people will have thyroid gland problems. But if they've got some reason to make you think they might have a pituitary problem, so for example, it's a lady that's had a history of postpartum hemorrhage when she was delivering, that can be associated with pituitary damage because of the hypotension during that postpartum hemorrhage. And you might think, okay, in this lady, I'll write down query pituitary disease, and that will allow Medicare to pay for the free T4 and free T3 as well. So these are the examples. These are just from the computer screen I use it at work. So this is someone who's presenting with primary hypothyroidism, so that's thyroidism secondary to the thyroid due to the thyroid gland. So you'll see their free T4 is below the reference range, and they've got a very high TSH, which is the pituitary trying to drive the thyroid gland to put out thyroid hormones. Sometimes the free T4 won't be that clearly low, it'll be sort of around the lower limit of normal, it could be just 7 point something. But the TSH is the body actually saying there's not enough thyroid hormone there, so the most important part is looking at the TSH when you're assessing thyroid disease related to the thyroid gland. As an example of hypothyroidism, so in this case the thyroid is overactive. These people tend to present with anxiety and palpitations, although they can feel run down and can be a cause of tiredness. Here they've got very high free T4 and high free T3, and what the body's done then, the pituitary says, well, this is really too much, so I'll stop making TSH to try and stop the gland from overproducing, but in fact, because the gland is producing just by itself, then the TSH is shut down, but the hormones still keep being produced. So that's an example of thyroid disease due to hypothyroidism. The other thing I was going to mention, I won't go through all those things, but this is basically the electrolytes, urea electrolytes and liver function tests. So if you have a look at the different parts of it, that's the electrolyte part. So we're usually looking at sodium, potassium, chloride, bicarbonate, and we calculate an anion gap. So this is just basically seeing if their salts are in balance in the body, and particularly the sodium. As I said, if you've got a low sodium, then it could be adrenal disease. You have a look at the urea and creatinine to see if they've got renal failure. The protein, albumin and globulin. Here it's a mildly low globulin, which won't be of interest, but what you're really looking for is a very high globulin that could be due to a reduction in a lymphoid malignancy. And then there's your liver function tests that you look at, seeing if there's anything disturbing the liver. So that's basically how you might use protocols to have a protocol to have a look at managing a tired patient, which is about 15% of general practice if you look at the figures. So has anyone got any questions on that?
We've checked in the ferritin.
Yes.
I know it did say other tests as required, but we cannot just do a whole iron studies. Quite often, like I'm working in general practice, so didn't they do my iron studies? And I go, oh, they've just done the ferritin. So why wouldn't you just do the whole?
Well, ferritin is the most sensitive thing for detecting iron deficiency. So what you're looking for is iron deficiency, so the ferritin's best. If you do the full iron studies, then what you'd also be looking at is whether the transferrin saturation is also changed. But iron studies, ferritin's the best way, just looking at iron deficiency. Or even for hemochromatosis.
Always the question, what's my iron level? It's not usually there, so now I know why.
Yeah. Well, I think it's tea time, is it?